Well, thank you, and good afternoon, Chairman Burke, Vice Chair Huffman, Ranking Member Antonio, and members of the Health, Human Services, and Medicaid Committee. My name is Spencer Cahoon. I'm an attorney, a Bexley resident, and host and producer of the Emerging State Policy podcast. In this podcast, we look at the research, impacts, and political leaning of lesser-known state policies. For our second episode, we focused exclusively on group prenatal care and its most common implementation, the centering pregnancy model. I have reviewed numerous research studies about the outcomes of centering pregnancy compared to traditional individual prenatal care, and have discussed the matter with Dr. Valerie Good, a family medicine doctor using the centering pregnancy model, Angie Truesdale, CEO of the Centering Healthcare Institute, and New Jersey Senate Republican leader Thomas Keene, who sponsored a bill supporting the expanded use of centering pregnancy in that state. From that background, I am here today to testify in support of the group prenatal care component of HB 11. Now, given the multiple presenters who have already addressed the centering pregnancy model, I'm going to skip the next paragraph of my written remarks so as not to duplicate their efforts. Ohio has, on average, 1,000 preterm babies born each month. Various studies suggest that group prenatal care through centering pregnancy has the potential to reduce preterm birth rates by 19 to 47%, which would prevent thousands of preterm births each year if it were implemented at scale in Ohio. This approach also reduces or eliminates the racial disparity in preterm birth rates. In recent years, Ohio has had a 49% higher preterm birth rate for Black compared to white mothers. The National Academy of Medicine published a 2006 report examining 2003 medical billing data to find that preterm births cost the U.S. $26.2 billion annually, with 40% of that cost coming from Medicaid and about 50% coming from employers, private insurance, and individuals. Ohio's share is $968 million annually in 2003 dollars, which equates to about $1.68 billion annually in 2019 dollars. Providing startup funding to expand the use of group prenatal care helps our children be healthier, reduces racial disparities, and recovers some of that ongoing cost which burdens our citizens, employers, economy, and limited Medicaid resources. This grant funding is critical to expanding group prenatal care, since healthcare providers must currently pay the upfront costs to implement and teach their staff this system. They do not receive any higher reimbursement that would help them otherwise recoup their costs. The savings accrues to Medicaid, insurance companies, and individuals down the line. This disconnect between the party paying the implementation costs and the party realizing the savings from improved healthcare outcomes has stood in the way of broader implementation of group prenatal care. These grant funds help address that disconnect by covering the upfront costs associated with starting a group prenatal care program so that providers are incentivized to implement this powerful model and achieve the related improved patient outcomes and system savings. By supporting this bill, we will follow in the footsteps of other states that have supported group prenatal care through either grant funding, enhanced reimbursement rates, or both. This includes North Carolina, New York, Georgia, South Carolina, Montana, Louisiana, Virginia, and New Jersey. Thank you, Chairman Burke, and the Health, Human Services, and Medicaid Committee for your time and consideration regarding HB 11. I'm available to answer any questions you may have at this time.
Very good. Thank you very much for your testimony. Any questions of the gentleman?
Thank you.
Seeing none, thank you very much.